Innovation is really important in breast cancer care. In our field, things are moving all the time and they move really quickly. There are always new techniques coming out and we were really hungry to see what was out there.
What Endomag has done is really engaged with clinicians to understand what are the areas that we could really help out and make a difference in. We've run over 125 clinical trials involving more than 12,000 patients internationally. And the feedback that we get from those trials really helps define not only how we develop and extend the utility of the devices that we make, but also find new ways to use them and help to advance surgical process.
As a designer, I'm interested in solving surgeons' problems, physicians' problems. I don't want to bring my technology and tell them it's what they need. I'm interested to talk to them, find out what their issues are, what are the challenges they face day to day in their surgery, and how can the technology help solve those problems. And that has been one of the secrets of its success, that it's really the surgeons have been involved in developing it right the way through. And so we know it's going to be something they like because they've developed it for us. The proof of that is in the data that you get when it's in use in real hospitals around the world. There are thousands of patients of clinical data on MagSeed. There are hospitals around the world where surgeons have done over 1,000 procedures personally. And that level of data and confidence shows that surgeons trust MagSeed, they can rely on it.
Whether a patient is having MagSeed to localize their lesion or they're having Magtrace to help determine if it's spread, both of those products simplify that process. They can reduce the pain that comes from injecting radioactive drugs, they can improve the accuracy of the surgical removal, and they can also reduce the anxiety that comes from the day of surgery. It's really our clinical data that is now driving further adoption in over 45 countries. More data than any other non-radioactive seed on the market. And that gives surgeons and radiologists confidence that this seed is simple to place, is easy to remove, and makes the patient pathway and patient treatment much better.
It was really good to see that there were large centre studies from MD Anderson, from San Francisco, a large study of EyeBraNet in the UK itself, where they looked at 35 centres in the UK using MagSeed, with thousands of women involved in that study. It really gave us the confidence as a unit to be able to see what people's experience had been and how best we can integrate that into our service and how it might look for our patients. The introduction of MagSeed and Magtrace to our patients has been a really important part of continuing our relationship. We meet people at their most vulnerable. They're scared, they're waiting for the news of their biopsies that have been taken, and we give them a diagnosis. By telling them that we've looked for new ways to make their experience better, they're able to understand what we are hoping to achieve for them. I hope they feel we've really got their back and we're able to give them something that is quite new, and they're part of moving to the surgical future, but also improving their experience as we go along.
So thank you, Maria, for doing all the legwork and hard work in trying to organize this webinar. So this is part of a webinar series that the Education and Training Committee for ESSO have been organizing for the general public out there who is interested in oncoplastic breast surgery and everything that is breast cancer. This particular webinar is on therapeutic mammoplasties, and with me is my usual suspect, Yazan, who co-chairs everything with me, so we can't be separated now. The terrible twins, you can call us. We've got a very good program, very good speakers, and I'll allow Yazan to kind of take you through what we have.
Many thanks, Ash. It's always great to see you all online and be among friends and colleagues. And it's a great session for ESSO, and it's great to see a couple of hundred people online. And the first speaker is also known to all of you, has been on those online sessions quite a few times from the other part of the world. It's Cicero, who's one of the consultants of oncoplastic breast surgery in Brazil. And he's a professor of bioaesthetics and scientific methodology at the Our Lady of Grace Hospital in Curitiba in Brazil. And Cicero is going to talk about marking and planning for various pedicles and pearls to avoid common errors. So the next 20 minutes are for Cicero. And thank you, Ash, Zoltan, and Peter. Maria?
Yes, sharing now.
That's great.
She's building the suspense.
Hi, I'm Cicero Urban, and I'd like to thank the organizers for inviting me to participate in this ESSO webinar. My topic is about markings and planning for various pedicles and pures of planning in oncoplastic surgery. I will present eight pures, and one golden rule for this kind of surgery. I don't have conflict of interest here with this presentation, and refinement means perfection. And this is the aim of oncoplastic surgery. I will divide my presentation in three different topics. The first one is to demonstrate the pures in a pre-op evaluation in oncoplastic surgery. This is the most important technical refinement. The second one is about how to do it, planning and technical details. And the third one, what is the best way to prepare the patient for this type of surgery, the golden rule. First, the pures in the pre-op evaluation in oncoplastic surgery. The first pure is that our most important failures in oncoplastics are not technical in the operating room. They are due to an error in judgment in the pre-op period. So, as important as performing a good surgery in the pre-op evaluation, more than 50% of success in oncoplastics is related to the pre-op. Few specific papers on this topic, on pre-operative evaluation in oncoplastic surgery. The exact incidence of contralateral procedures for symmetry, for example, is unknown, but it ranges from 15 to more than 90% of cases in breast conserving surgery and in mastectomy. And what about the rationale of oncoplastics? The rationale of oncoplastic surgery is not aesthetics, it's symmetry. And whenever possible, of course, a beautiful breast, but the rationale is symmetry. Our aim is symmetry. And this is the virtuous trial of decisions in oncoplastics. Evidence-based medicine, experience, ethics. Let's go to the second pillar, quality of life. Quality of life depends directly on our decisions in surgery. Breast cancer, unfortunately, is a history of expectations and fears, and one size does not fit all in surgery anymore. It's necessary to individualize the surgery as we have a great individualization in adjuvancy, in neoadjuvant treatments, immunotherapies, and so on. We are living a new paradigm of oncoplastically thinking, combining skills of cancer surgery with plastic surgery. If in the beginning, with the breast conservation surgery, the aim was to avoid mastectomy, the aim now is symmetry and appearance, not just avoid mastectomies or unnecessary mastectomies. Ethics. Now it's necessary to understand patients' expectations and to respect patients' autonomy. So breast cancer today, breast cancer surgery is always and should be always an oncoplastic surgery. the combination of quality of life, the combination of concerns with symmetry, with aesthetics, and with patient's autonomy. Oncoplastic surgery is, I like this point of view, oncoplastic surgery is an aesthetic cancer cure. It is not an aesthetic surgery, but it is an aesthetic cancer cure. And it's necessary to change episodes. Breast is an aesthetic and functional organ. Rigid boundaries between surgical oncology and reconstructive surgery compromise the final result for the patient. And what about beauty? The third pillar, beauty matters. Beauty matters for the patients. It is not just a subjective thing, but universal need of human beings. If we ignore this need, we will find ourselves in a spiritual desert. This is a philosophical point of view. But if we go to Ivo Pitangui, the famous Brazilian plastic surgeon, he said that the concept of beauty undergoes variations that are determined by different ethnic groups. Beauty, by the way, is something I could never define. But every time I find it, I know how to perceive it. So, beauty matters. Beauty matters, and we have a problem in breast conserving surgeries. We have about 30% of dissatisfaction with aesthetic results, 30% of poor cosmetic results, and asymmetry is related to fear of death, fear of recurrence, fear of losing femininity, losing quality of life, depression. So we had to be with this concept inside us when we do breast surgeries. How to do it? Some important technical and planning details. It's important to do a precise documentation with well-taken photos in the same positions. It allows us to compare the pre and post-op results and to show to the patients, because sometimes the patient has some expectations with this kind of surgery. And if we don't have a good documentation, it's not possible to prove that, for example, some asymmetries are already in the back best of the patient. The fifth pillar, know how to see the breast objectively. So bases, shape, ptosis, projection, volume, nipple and areola complex, inframammary crease, and so on. How to plan for the symmetry, how to see the breast and plan the symmetry. So if we have volume discrepancy, it's necessary to do a reduction or an augmentation. If we have shape discrepancy, it's necessary to do a mastopexy, a plan for the mastopexy. Contour discrepancy, lipofilling, and no discrepancy, please don't touch. Sometimes patients want us to do something that's not necessary, so don't touch when we don't have discrepancy. Oncoplastics is an aesthetic cancer cure, but it's not an aesthetic surgery. The wishes and expectations of the patient matters, so it's necessary to understand what patients want. Well, symmetry planning, how to do it in a good way. We can see that both breasts are not symmetric. Right breast is bigger than left breast. We have maybe the inframammary crease in the right side is a little lower than the left side. Nipple and areola complex are in different positions. So when we do the symmetry, we should understand how to see the breast and where it will be the right position for the nipple and areola complex. Where is the right position for this? And it is necessary to have a good background, a good training to see where it is the best position to put the nipple and areola complex, to do the right draws, because pre-op is the most important time for this kind of surgery. The planning is fundamental to the success of this surgery. As we can see here, this patient, I will do the draws. So the patient is in a stand position with a calm music in the back, because patients are very anxious. In the back, I have a blue wall that we can see better the differences between one breast and other. The inframammary crease, the median line, inframammary crease, sternal notch, the inframammary crease in the contralateral breast. The breast meridian. The A point where I will put the superior part of the new nipple and areola complex. It's important to measure. Don't go beyond 17 centimeters. The other side, I will do after the right side. Consider that every one of us, we have an eye which is better to see the symmetry. My eye is the left eye to see better the symmetry. So I begin in the right breast and do the left breast after the right breast. But maybe some of you have differences in this preeminent eye to see the symmetry. It's necessary to train it and to see all the patients in a stand position and to learn how to see the differences between one breast and other breast. So I put 5, 4, 4 in the nipple and areola complex, and in the inferior line I put 7 centimeters usually, most of times. Then I'm doing the Ys in the right side, and now I'm going to the left side. Same thing. Breast meridian. It's necessary to use this to measure one and other side. If I am in the right breast meridian, in the right side and the left side, because at the end it should be symmetric. So the eyes should be trained. Again, measuring it. 5 centimeters, 4, and 4. This is a magic pen. These 5, 4, 4, and 7 are the boundaries. So I cannot cross these limits, but I can do less than 5'4". I can do less than 7 centimeters whenever is necessary. So 7 centimeters now.
Vira um pouquinho de lado. Levanta um pouquinho o braço, assim, isso.
And the same Ys that we did in the other side.
Pode virar de frente.
Well, that's the patient before the draws. That's the patient after the draws. And what I was seeing before doing the draws. So very close to my view before. The sixth furor. Well, master all techniques. It's necessary. Tumors, when you master all techniques, we can remove tumors in all the quadrants. Mastering 3 techniques, for example, superior pedicle, inferior pedicle, and round block, we can we can solve more than 90% of our cancer cases, of our breast conserving treatment cases. And of course, oncoplastics is an individualized surgery. We should consider where the tumor is, the grade of ptosis, the size of the breast, the position, the symmetry, and so on. Then we can individualize the best technique for each patient. Knowing how to see the breasts is more difficult than making pre-op drawings. That's a good point. And making pre-op drawings is more difficult than doing the surgeries. And then pre-op time is more demanding than operative time. So see the breast is more demanding than do the drawings. And both are more demanding and more difficult than do the surgery. That's an important point. The seventh pair. What is the best way to prepare the patient for this type of surgery? We must understand the expectations of the patient before any breast surgery. The critical and ethical point is to understand the expectations of the patients before any breast surgery, the driving force in patient's decision. Sometimes the patients want to preserve the naturalness of the breast and or get the lowest local recurrence risk and eventually larger, equal, or smaller breasts. So it's necessary to understand it when we will perform the surgery before to understand the patient's point of view. The eighth pair, the perception of symmetry and aesthetics is different between doctor and between patients. We did this study some years ago and published in Annals of Surgical Oncology, and we had big differences between patients, between specialists, and between the BCCT core score. So we must take care of this before do the surgery in order to avoid unsatisfaction by the part of the patients. The golden rule. That's the most important point here. What is the golden rule? Lower expectations, under promise and over deliver. Oncoplastics is not cosmetic. This is not cosmetic surgery. It is an aesthetic cancer cure, but not an aesthetic surgery. So we have more limits than in aesthetics. And patients must be aware of this point in order to don't be unsatisfied with the final result. I invite you to read this editorial written by Scott Spear about under promises. We wrote a letter in response to this, and it is very important. Aesthetics for symmetry, what's the aim of breast reconstruction? The aim of breast reconstruction is symmetry more than aesthetics. So in summary, C, know the breast aesthetics of the patients. Predict how the long-term consequences of cancer treatment will make differences between the symmetry of the breast and in the aesthetics of the breast. Respect autonomy, know the patient's wishes, and master all techniques. Well, the postmodern breast surgeon, us, of course, we should think oncoplastically. I wish to thank to my team in Brazil and also to my family. And thank you to all of you for being part of this great ESSO webinar.
That was a great talk. Thank you, Cicero, for that. And I think everybody will want to know where we can buy the magic pen from. Now we move from South America to Europe, and the next speaker will be introduced by my co-chair and my previous boss, Kothari. You're on mute, Ash.
So our next speaker is in Rome, and he's sitting there by this very nice painting that you can all see. I would describe Peter as a good friend, but as a clinical scientist, because he does everything is driven by science, by knowledge, by his techniques, and no better speaker to give a talk on tips and tricks on therapeutic mammoplasty than Peter, because he is driven by anatomy, by blood supply, by everything that you need to do to get a good result and avoid problems. So I'll hand over to Peter, who's an oncoplastic breast surgeon at the Royal Marsden, for his talk. Instant results.
Thank you so much. Can you hear me?
Yes, we can. Thanks.
Thanks, Ash. That's a very kind introduction. I must say I'm feeling much more relaxed after Cicero's music and his amazingly wonderful, philosophical and wise talk. I mean, I just think it's impossible to follow. I'm going to give you a bit of nitty-gritty now of what I tend to do every day and how things work here. So I'm from London, but talking to you, as you mentioned, from the internal city, which is maybe the best way to be. So I'm going to talk about a few markup essentials, very little after that wonderful talk, but just a couple of things. The pedicles in mammoplasty I'm going to talk about mainly for complex, more complex mammoplasties. I'm not going to spend much time discussing round the block because I think most of us can comprehend that without talks like this. We'll talk about some of the cancer resection considerations, talk a little bit in that way as well about skin pattern versus pedicle pattern resection. And then I'm going to talk a little bit about tailoring the neck, a little pet topic of mine that you'll hear more about in coming meetings as well. So the first thing is with the markup, keep it simple. You just saw a very elegant and erudite presentation. I mean, what a simple markup it was. It was simple and elegant, and it did everything that it had to do. So, you know, you'll see mine are much messier than Cicero's. The second thing I would just say is, you know, again, the obvious, and Cicero pointed this out, but look, you know, make sure you and your patient are symmetrical and level on, that the patient, you know, is sitting in a comfortable way and actually you're seeing the reality, not something distorted like this, for example. The final word on markup I'm going to say today is just notice when the patient is asymmetrical. Sometimes it's obvious, but sometimes it's the first thing that we forget to document and realize, this is the time to make the patient aware. Often they are aware when it's long-term, but and not in a derogatory way by any means, but just to make them aware of how they are now, because again, this is, you know, expectation setting. So if you look anteriorly, you can see the significant discrepancy both from the side and the front in this particular patient. Well, this is my typical patient most weeks for a mammoplasty, and this is the WISE pattern that you've just seen, of course. And I want to just mention too that sometimes we do vertical scars as well, but sometimes there's a discrepancy between what our skin pattern is and what the parenchymal resection pattern, as in this case, for example, a WISE resection, but with a vertical scar pattern. And note the pedicle here drawn in, which is in this case a superior medial pedicle. So just to mention, it's not always the same. You can have WISE resection or vertical resection, but still a different parenchymal pattern. So let's talk a little bit about the types of pedicle now, because this is really important. And a pedicle, of course, is a tissue subtended by blood supply. And in the case of the neck pedicle, which we also call the primary pedicle in therapeutic mammoplasty, is a cutaneoglandular pedicle, of course, always. The parenchymal pedicles, which we also term secondary, are dermoglandular, but of course, sometimes when there's skin involvement and we need to replace skin oncologically, they can also involve skin replacement. And of course, these secondary pedicles can be based on perforators, especially septal, which of course is the topic of the next speaker. So how do we image blood supply, which of course is critical to all pedicle vasculature and survival. And for example, nowadays we have MRI available in many patients, particularly with lobular carcinoma, and we can see, and we should practice visualizing these vessels because they're very beautifully displayed. And these are the second anterior intercostal branches, which of course supply the superior pedicle for the neck superficially. And the third intercostal arteries, which are a little bit further away, slightly smaller on this view. And of course, we have the lateral thoracic supply, and again, an important contribution in many patients. Now, the patterns, of course, between patients and even between sides is very variable based on personal experience, but also on the literature. And you can see them in the different views, both sagittal and axial here on MRIs. So let's see how this correlates now with what we do with the neck pedicles. So this is, for example, a lateral pedicle based on an LTA superficial branch. I've probably drawn it pretty poorly here, actually, because it's usually much lower and lateral if you want to find this. So it really is truly lateral and maybe much lower down. The superior vessel from the second intercostal, of course, classically is just medial to the breast meridian, but is variable. And the medial pedicle, again, from the third intercostal, is generally reasonably predictable. And I would say probably the most robust and predictable of all the vessels for these pedicles. And of course, the most common go-to pedicle, particularly for the symmetrizing or aesthetic, if you like, mammoplasty, is the combination of the superior and medial pedicle to give you a very robust supply. And we'll come back to this. So what about septal perforators? Well, just again, briefly, not to overlap too much with Zoltan, but you can often see these as well very beautifully. And in this case, a very nice illustration of what is classically thought to be the supply of the inferior pedicle, which is the fifth septal intercostal perforator. And of course, this is why you need a full thickness of parenchyma with the inferior pedicle, in contradistinction to the others, lateral, supra, and medial, where it's a superficial branch. And that's why we can thin out the pedicle in the other cases, but not in the inferior pedicle case. We must remember that. Well, what about cancer considerations? Well, I've already mentioned this point about skin versus parenchyma. When there's a mismatch, there's always going to be undermining. So be very careful and try and minimize this in patients who have vulnerable conditions which make healing difficult, such as diabetes, smokers, COPD, anyone with a generalized problem with perfusion. Keep the options open until the end of the procedure. My general advice is keep pedicles short. I prefer many short pedicles versus one very long one. And it's an iterative dissection. So deepithelialize everything. Keep it very simple, and at the end, you make your final decision. Sometimes I only decide whether I'm going to use an extended or a secondary pedicle at the very end. And even which secondary pedicle do I use? Well, often it just is which one goes the best, which one flops into the right place at the last moment in the best way. And then you make a decision to divide that tissue and divide blood supply, which is generally not a reversible decision. So make it at the end. So primary pedicles, let's go quickly through this. Well, the vertical scar pattern, again, if the cancer is within the standard resection, then it's very easy. And here's a superior pedicle with a high nipple areolar complex. It's very difficult to do anything other than that when it's that high. But when it's a bit lower than the cutout, you can have the option of a supramedial or medial pedicle and rotate it up into the defect. What about the WISE pattern? Well, this is for many people the standard one, and I tend to use WISE pattern when there's poor skin quality or very significant ptosis, and I know that the skin's just not going to retract back up after a vertical mammoplasty, and we can maybe discuss that later. Again, the cancer in the standard resection pattern could be above in the top of the keyhole cutout, in which case an inferior pedicle is most appropriate. And that'll be then pushed up. But if the cancer is in the lower part of the standard cutout, then clearly a superior or supramedial pedicle would be the most desirable one to affect that resection. Now, this is the before I forget slide, because it's also the thing that I forget at the time of the operation, which is the little T-junction triangle. Now, some people prefer to just do a dermal pedicle or dermal flap there and deepithelialize this. I personally like to actually keep some skin there because it means that I can then shorten or I can make a looser flap closure and make that T-junction less vulnerable to wound breakdown. Because if the one thing I tell every patient is, if you're going to get a wound complication, it's going to be the T-junction. And if you can minimize that, then that's one little pearl, if you like, for this, this whole talk. Okay, what about for cancer outside the resection of the standard WISE pattern? Well, 3 steps here. Plan but be flexible. Skin markings come first. I tend to then focus on the neck pedicle as the next issue and get that out of the way, and then filling the cancer defect. And there are 2 solutions generally, but there may be more. Extending the neck pedicle as what we call extended pedicle on a broad base, which we'll talk about briefly. But my favorite one is, of course, the secondary pedicle, which is generally based on an axial vessel, perhaps a septal perforator, and of course intact dermis, as we depend on the dermal or subdermal plexus for these as well. And I think when you decide, again, consider the perfusion and the patient's mobility, but where there's choice, keep the pedicles short. And of course, there's another option where you can rotate the entire template if it suits the situation better. So let's look at some extended primary pedicle examples. Just one here, 12 o'clock cancer. But what about the one that's outside the resection template? Then you can do an extended pedicle in this instance with a broader base and just advance the whole thing and close that. And that's certainly sometimes useful when you can't reach with any other pedicle, but I would caution its use. My far the most reliable, I think, technique is to use one of this is an extended pedicle from supromedial. Again, this is probably a slightly more robust pedicle. Again, you extend the neck pedicle and you can rotate it up. But again, it depends on the pliability of the breast tissue, because if this is a very stiff, fibrous area, especially subaerially, it may not be possible. And then, of course, you need to depend on secondary pedicles. So here's an example of the lateral part of the secondary pedicle. This is the lower tissue that we normally throw out or discard in a standard symmetrizing or cosmetic reduction. But of course, we've now separated the neck pedicle from the secondary pedicle. And another very important principle is to try and keep the neck pedicle as far away from the cancer as you can. You don't want that anywhere close to the margins if possible. And then, of course, we can use that secondary pedicle now. Usually it's kept on one of the anterior intercostal perforators or the medial one, and that can be rotated in position as you then advance and close the breast superiorly, and that usually works very well. And the same thing with the medial side. Well, again, keep the neck pedicle away from the cancer. The cancer here, in this instance, happens to be partly within and outside the template. And here's my pedicle, which in this case is a supralateral pedicle. Well, I'm going to give you a couple of examples of mag seed localization and bracketing. This was done with a round block mammoplasty. So again, keep it simple where you can. If a round block where you have minimal ptosis, maybe just a couple of centimeters of ptosis, and you can get away without having to do a vertical scar or WISE pattern, that can work very, very well. What about 2 mag seeds in a different configuration? Again, here we have 3 cancers, and you can do this en bloc in one specimen. This required a therapeutic mammoplasty with WISE pattern. And again, we have even more foci getting ever more complicated, and this one required a secondary pedicle. So think 3-dimensionally. There's our mag seeds. And again, another case that you might look at and think, well, this is definitely a mastectomy, but as long as you mark everything early on, this patient had neoadjuvant chemotherapy. And when we talk about this, I think of this as one cancer with some satellites. This to me is not even really multifocal. It just has satellites. This is the second focus. So we mark this one, we mark this and this around the cancer, and these are all lymph nodes. This lady got a complete response. Should we do a mastectomy and reconstruction when there's no cancer left? I don't know. I'll leave that question to others. But I think it's possible. You have to challenge yourself. And I think we're going to be doing more and more complex surgery as we go forward. So look at all the views, because here are 2 mag seeds in the breast. And this will be my last mag seed slide, I hope. But it's just to show that when they look close together, if you look at the other view, these are actually 10 centimeters apart. When you look at it in the correct. So always think of the view where they're furthest apart, not where they're closest together, because that will give you a true appreciation of that segment you have to remove. This is still a segmental disease, just an unusually oriented one. Well, just a word about, your best friend here is your radiologist. I mean, we really depend on our radiologists. We need a close communication with them, build a relationship with them, and because you need to work really closely. They need to understand what you're trying to achieve. And I think that's absolutely imperative in this day and age. And no longer should the radiologist be dictating the operation. No, you need to work closely with them, and this is all very possible. Well, another example where you've got multiple cancers in that sort of supramedial lateral aspect of the breast, you can do a WISE pattern here. You can see an inferior sort of pedicle or even a septal perforator, if you like. But you can also use a spare pattern, which I won't go into today, but that's another nice option for this distribution of cancers. And in the future, one day, we'll have tools like this, maybe wearing VR goggles, so we can really visualize from every angle what's going on, where the neck pedicle supplies as well. But what about today? What can we do today still that maybe we're not doing yet, but should be? So I want to introduce you to a small feasibility study that we've done at the Marsden with a fellow of mine from Rome, Lorenza. She's right here actually with me. So the challenges, the current problem was, and the background to this study is that our trainees found it difficult to mobilize and inset the pedicle, especially with supramedial and lateral pedicles. They struggled, and the patient had very fibrous tissue. They were worried about dividing the blood supply. And of course, this is where you have to help and support them and do it. But as consultants, if there are any consultants participating today, we all have that little bit of a feeling, can I just do a bit more? Is it a bit more? Is it too much? A bit more, a little bit more. How much is enough? How much is too much when you say, whoops, I've taken a bit too much. Now I have to maybe free graft or just pray for the next few days that this works. Well, we have lots of documented patterns of the blood supply. It's variable, we know that. And we just happen to be in a situation where UK trainees in particular are learning how to do chest wall perforator flaps and learning the acoustic Doppler device. And of course, we know that venous congestion is a consequence of lack of mobilization, actually having too bulky a pedicle. And these things do happen. It will heal eventually, but we don't want this sort of thing to happen. We want to minimize this. So what about individualizing the neck pedicle design? Well, what we do is we use Doppler, acoustic Doppler, and color Doppler imaging to mark the pedicle. In this case, just a medial vessel in this patient, which was dominant. But I'm going to show you the value of being able to do this. So you can see on the left, here are our marks for the superior supply and the medial pedicle supply. And the value of this is I'm now going to quite calmly back cut the dermis because I know where to stop. Now I'm actually deliberately sacrificing the superior pedicle in this lady because her pedicle was never going to rotate and to fill the defect. She was just too stiff and too bulky. And here again, we can go close to, but of course not up to the medial pedicle, because in her, the medial pedicle is dominant. And I'm confident that this is going to survive on the medial pedicle. And here, just to show what a good medial pedicle it is, if you listen. A very nice Doppler signal. And there we have the venous signal as well. So by use of these techniques, we can now start to map things. So here's a slightly complex case. This lady had a mag seed laterally. She's got some microcalcs laterally extending below the neck deeply. And here's the palpable cancer medially. And you can see we've marked 3 vessels, one within the circle, a medial one, a superior one, and a lateral vessel, which is probably also superior. We did an ultrasound. And here's the cancer, and we can see the vessel, very small, but this is the small one here, just a centimeter, within a centimeter of the cancer. So we decided actively to sacrifice this vessel. Okay, the other one is a dominant vessel. You can see a lovely bright signal there for this dominant superior perforator. And given where the cancer was, we kept the pedicle just on a single dominant perforator, and that worked very nicely. Now, my final slide is not to steal Zoltan's at all, but it's just to show that we can extend this to help you find the septum. And I still use the Doppler just to help me become a little bit more secure when I'm looking for the septum. I'm not quite where Zoltan is yet, where I can just mobilize it in his technique. But I'm just going to find, oops, sorry. There we are. I'll just start this video. It's just a nice triphasic vessel, basically. So that's a nice vessel there, nice signal. And just to show how we... It's just a nice triphasic vessel, basically. So that's there. And that was from the medial segment that we resected. And we're just insetting that now into the central breast to give a little bit of projection to the nipple areolar complex. So it shows now we can extend these techniques very nicely. So what I want to show you is a study, a multi-center study. This is a plug now. If you're interested in learning about this and also contributing to a multi-center study using either the acoustic Doppler or an ultrasound, we're very keen to have you on board, anyone out there. And so please just email us to mapnacstudy@gmail.com, okay? We can maybe circulate that later. So my final reflections, if time permits, is know your patient, their wishes, expectations, but also what's possible, the reality, just as beautifully outlined by Cicero, cancer versus aesthetic. Keep things simple, okay, especially with multifocal, multicentric disease. And, you know your limitations too. Don't bite off too much. And if the patient is also doubtful, then I think, start to listen to the patient. So I think sometimes we go a little bit too far to trying to conserve the breast. Just know the limitations of what you can achieve and start simply. Careful selection. Short pedicles are safer than long pedicles. And that's my order of preference. No pedicle versus primary versus the secondary pedicle. Keep the neck as far away from the cancer, decouple the cancer and the neck pedicle. Ptosis is your friend, not your foe in this situation. So, use that as your friend. Medial fullness is generally preferable to lateral fullness for most patients. So again, another little, a tip in terms of expectations. And finally, don't discard anything until the end. If unsure, deepithelialize everything and then make your decisions at the end. And remember the triangle. That's all. Thanks very much.
Thank you, Peter, for that masterclass. Brilliant, brilliant compliment to what Cicero showed. The anatomical contribution, as I predicted, was there, which was brilliant. Thank you. Clarius is a very good device. I'm trying to get one, and yes, we can see your lovely assistant now there. So thank you so much for the talk. We will now move on to Yazan to introduce our next illustrious speaker.
So the next speaker, we move from Europe now to the Middle East with a European flavor, with a speaker that's well known in Europe, that was the head of the surgical department and the surgical oncology department in the National Institute of Oncology in Hungary, but has now moved to Hamad Institute in Qatar. And Zoltan is well known. If we start telling you all the positions that he had in Europe in the past, then we will have no more time for this talk. And Zoltan is going to tell us about septal mammoplasty. I've seen this talk more than once or twice now, and each time I get amazed when I see the results of that. The science, indications, and techniques of septal mammoplasty. Zoltan, the next 20 minutes are all yours.
Can you see the screen? Can you?
Yes, we can. Yes, we can. Thank you.
Dear colleagues, ladies and gentlemen, my name is Zoltan Matrai. I'm a senior consultant at the Department of Breast Surgery, Hamad Medical Corporation, Doha. And it's a great honor for me to be lecturer at the ESSO Advancing Surgical Oncology for the Benefit of Cancer Patients webinar. I would like to share my experience about anatomic or septal mammoplasty, the science, indications, and techniques. I have no conflict of interest. The hypothesis of anatomic breast conserving surgery was first published by Thibaut Todt, who is a pathologist from Sweden. And according to the hypothesis of the cyclope, the breast carcinoma is a lobar disease in that the simultaneously or asynchronously appearing in situ or invasive tumor foci develop within a single cyclope, and the cancerous structures are confined to the area of the cyclope at the early stage of the disease. The cyclope probably contains more and more sensitive committed progenitor cells than the other lobes of the same breast, and is more sensitive to exogenous or endogenous oncogenic stimuli. Another important publication related to the topic already integrating anatomy, radiologic, pathologic and surgical aspect as well. And according to that publication, the cyclope hypothesis provides the basis for a lobar approach in radiology, pathology and surgical treatment of breast cancer. This approach aims to remove the tumor together with the surrounding field of genetic aberrations. And according to that hypothesis, this is the main concept actually. Detailed preoperative lobar imaging that properly maps the disease and assesses its extent guides the parenchyma resection. Integration of our knowledge of breast anatomy and pathology with the results of preoperative radiological mapping is critical in assessing the eligibility of patients with multifocal or multicentric breast cancer for breast conservation treatment. So an appropriate selected incision, a multi-segment resection of the diseased lobe is performed, which leaves a residual parenchyma in a formation that allows a dovetailing of one part into the other, like the wave pieces of jigsaw puzzle fit together, and this is nothing else than oncoplastic breast surgery. Even though not at all had published the theoretical basis of lobar surgery, they only reported a simple V-plasty as an oncoplastic method in the related publication. Together with our colleagues, pathologists and anatomists, we started to think about that problem and about this hypothesis. And of course, the first step was to gain more information about the detailed anatomy of the breast. Here you can see the septal system and the inner ligaments of the human breast. And here the sagittal view of the human breast on the thoracic wall. Here you can see the breast parenchyma sitting in the fibrotic structure. Here the ductal structure of the breast is presented in details, prepared by the use of the retrograde filling the ducts through cannulation of the orificiums of the mamilla by a special red-colored synthetic resin. Even the ductotubular units are visible. Different colored synthetic resins were used for the separate orificiums, and so different breast lobes were successfully made visible. Of course, not only our team was able to have such kind of detailed results according to breast and lobar anatomy, then Going et al. Published the same result. We have reported the central pedicle modified vise pattern surgical technique, which allows the accurate access and radical surgery of the targeted lobe completely from the periphery to the retromammillary tract. The success of anatomic breast conserving surgery is obviously based on the knowledge of vascular anatomy of the breast. Some vessels have paramount importance for the safe anatomic breast conserving surgery, then the lateral mammary arteries, superior mammary arteries, the medial perforators or perforators located just below the IMF. The perforator vessels located in the horizontal fascia doubling called Wöhringer are very, very important according to our concept. And of course, one tiny artery located in the axis of the nipple has paramount importance. And of course, the subdermal vascular plexus. Here you can see the extreme mobilization of the parenchyma with the nipple complex supplied by the perforator vessels mentioned before, located in the Wöhringer horizontal fascia doubling and preserve dermal and subdermal plexus around the nipple complex. Here again, the shiny layer of fascia of the Wöhringer septum and the perforator vessels located just below the fascia layer. The Wöhringer horizontal septum in a cadaveric preparation. Here you can see as well, very visible. And again, the perforator vessels of the Wöhringer septum. Perforator vessels located in the Wöhringer septum, the different calibers is good visible if somebody is using the scalpel for a standard mastectomy. The dermal or subdermal vascular plexus is very, very important for the adequate vascular supply of the nipploral complex or the remnant parenchyma. Here, the preparation of the medial and lateral cutaneous pedicles just above the superficial pectoral fascia lamina anterior. Here, the lateral mammary vessels, the cranial branch and the caudal branch of the same vessel. The superior mammary vessels are visible. Here, the digital subtraction angiography of the left internal mammary artery. And here on the CT angiogram, you can see that especially the second intercostal perforator and its branches can be long followed through muscle and in the subcutaneous layer as well. Parasternal perforator vessels, prepectoral and subpectoral location visible. How to find the involved lobe? MR-angio can help to find it. Here you can see the tumor and the supplying vessels that can help the surgeon to prepare for that lobar breast conserving surgery. Here you can see the nipple after coring and the medial skin flap and the medial and lateral skin flaps. And caudally, you can see the dermal flap from the lower part of the breast. The translamination of the dermal flap, which is based on the subdermal vascular plexus, as mentioned before. The preservation of that subdermal plexus is only possible with accurate and untraumatic deepitalization. So, if we have the theoretical knowledge and we are able to perform lobar surgery for the liver, for the lung as parenchyma organs, are we able to perform lobar surgery for the breast as well? The answer is yes. With the use of that kind of modified therapeutic mammoplasty, I will show you that we are really able to dissect the interseptal spaces and even able to resect the whole involved lobe or sick lobe from the periphery till the retromammillary area. As well, we are able to dissect the central ductal branch using the microscope. And so we are able to do complete lobar surgery. If we are able to do that in the future, there adjuvant radiotherapy is really necessary in all of the cases. So let's see what we have as experience with that kind of lobar surgery. Here you can see the resection of the complete upper parenchyma hemispherium. The deepitalization was already performed, and the parenchyma is mobilized and already elevated from the major pectoral muscle. You can see that the Weringer fascia is even bluntly divided, and the center of the mamilla is even reachable with a forceps or even holding my right hand, as you can see. On even 4 of my fingers are already placed in that interfascial space of Weringer. In the right pics, you can see that the complete parenchyma is turned from the inside to the outside, like a cab. You can see here, and probably you can understand that or imagine that situation of upper hemisphere and lower hemisphere, and the border of them, between them, the Weringer as a Weringer horizontal fascia doubling, If you imagine my 4 fingers like a cap, and that situation, if the cap is turned from the inside to the outside. So you can see here the extreme mobilization of the parenchyma by dividing along the Würinger fascia doubling, supplied by perforator vessels and preserved derma and subdermal plexus. Here's the axis of the parenchyma, and the forceps is marking the half line of the breast via the Würinger septum, and the perforator vessels are good to be seen. They are rising from the major pectoral muscle. The residual inferior hemisphere and nipple-auroral complex after the upper hemispherium or biquadrant resection. Here the end result, just after the operation, you can see all the skin flaps and the nipple-auroral complex is well vascularized, and you can see that our specimen, the largest diameter is more than 15 centimeters. Here another case, again a complete upper hemispherium anatomical resection. You can see that the tumor and the extended microcalcification. And this is an MRI before the neoadjuvant chemotherapy, and the situation and the tumor extent after significant regression after the neoadjuvant or primary systemic treatment. Here, because of the extended microcalcification, an anatomical breast conserving surgery was performed, and you can see that the central pedicle modified Weiss technique and the creation of the dermal flaps was performed already. 9 and 3-year positions are marked by ink on the parenchyma after the preoperative localization of radio-guided occult localization of the extensive microcalcification and the anatomical mobilization. And here the imagination of the lobar structure and the imagination of the position of the nipple-auroral complex from the posterior side. The complete anatomical dissection of the central ducts of the involved lobe is with high importance, necessitating accurate retroaural and retromammular preparation. For the survival of the nipple-auroral complex, accurate deepitalization and preservation of the dermal and subdermal vascular plexus is really mandatory. Dividing the central ductal branch retromammillary according to the upper parenchymal hemisphere. Here you can see the blunt and sharp dissection of the involved lobe and the retromammillary ductal branch and space. One can even bluntly do the dissection according to the definitive layers if the breast is fatty degenerated. The residual lower hemispherium after the anatomic parenchymal resection, of course, that necessitates some tricks to be able to fulfill the empty upper pole of the breast. Here the end result. In some of the cases, partial thickness skin necrosis is visible, like in that case, and you can see that it healed after conservative treatment. The specimen mammogram revealed complete resection of the microcalcification, and the histologic end result. You can see even in Hungarian language that the extent of the specimen was huge, 23 centimeters to 18 centimeters to 6.5 centimeters. And there was DCIS with an extent of 85 millimeters, and another one is an extent of 45 millimeters. And the closest margin was 2.5 millimeters. So the resection was radical. Here a case is a gigantomastia, with extreme ptosis and extended DCIS involving the upper hemispherium or upper lobes. Here you can see the extended microcalcification. Because of the long dermal pedicles, the McKishop type of dermal pedicles are preserved to be safe enough to have adequate blood perfusion of the nipple complex. You can see the upper pedicle, lower pedicle, and central pedicle for the nipple complex. Again, the anatomic dissection of the upper quadrants or hemispherium of the breast. The substructure of the nipple and retromobility central ductal branch is well known, reported. Here you can see a publication by Going et al. The central ductal branch had been prepared till the nipple here. And in another case, again, you can well see the central ductal branch. We are just below the nipple. It's actually nipple coring already. The complete upper hemispherium is resected. One should make attention that by ptotic breast, the upper parenchyma hemispherium forms up to 7% of the whole volume of the breast parenchyma. Here, the prepared deepitalized dermal layer. Here, the specimen mammogram, complete resection of the microcalcification. The well-known suffusion just after the operation and just after the end result after the whole breast radiotherapy. Here again, the histological end result, 12 centimeters by 21 by 2.5. The extent of the DZIS was 115 millimeters, and the closest margin was towards the skin, 1 millimeter, but towards the parenchyma, all the surgical margins, the circumference surgical margins was more than 10 millimeters. So what if we have a really multicentric cancers? Breast conserving surgery is acceptable as an adequate treatment for these cases, but how can we perform that for really multicentric tumors? Here you can see that the tumor fosses are located in the lower outer quadrant, non-palpable, and another one in the upper inner quadrant. The lower outer quadrant tumor was located using the radio guidance, and the upper inner quadrant tumor used the wire guidance. Because of the, again, safety reasons, a tissue dermal pedicles preservation was chosen. Here you can see the complete resection of the lower outer and upper inner quadrants, or we can say lobes. Nipple is widely undermined from both directions, and dermavascular supply ensures the survival of the nipple complex. Here you can see the situation after resection. A close view, you can see the complete lower outer quadrant was resected from the periphery till the nipple complex, and the complete resection of the upper outer wall. Imagination of the lower structure of the breast and the end result of the patient, of the cosmetic outcome. Of course, there are a lot of further questions, like the exact borders of the involved lobe, the connecting areas, or ductal systems, or overlapping of the adjacent lobes. What about is our resection complete or not? Large format histology technique to prove that the whole breast lobe was resected would be necessary. Exact preoperative planning and imagines, which are the techniques which could really support and help the surgeon, probably the angio-MRI. If parenchyma is not fatty degenerated, are we able to perform such kind of surgery? I think not. We are not able to do that. Only in fatty degenerated breasts, and of course the long-term oncological results to gain more information and evidences with anatomical breast conserving surgery, not mentioning the adjuvant radiotherapy, the indication, yes or no, if the complete lobe is being resected. Thank you for your kind attention. I hope I was able to present you our experiences with lobar, septal-based or anatomical-based breast conserving surgery. Thank you for your kind attention.
Fantastic. Great talk again, Zoltan, as usual. And if we all just open the cameras now, because we need to start having the discussion and the chat.
And we have Cicero now, who's joined us live.
Hi, hi.
Hi, Cicero. Welcome. Welcome.
I escaped from the conference. With you.
So we have some questions in the Q&A box. Yazan, do you want to do those, or do you want to have a little panel discussion?
I think let's start with the questions in the Q&A box and finish those, and when we will do our discussion. What do you think, Ash?
Yeah, I think we have about 260 people, which is a record for ESSO, which is good. So let's give them their answers.
So the first question that has been kindly answered already by Zoltan is from Basma Al Sayed, asking about how to avoid flattening of the nipple, which happens after reductions. Do you want to mention your answer that you already mentioned, Zoltan, for everybody?
Actually, our colleague asked us that in her practice, the nipple is tendentially flattening after the inverted T mammoplasty, and she asked about how to prevent that. And I think in my practice I have not that kind of result, and probably as an explanation for that experience, I answered to her that probably it's a significant discrepancy between the so-called inner circle, that the perioral incision, according to the neo-nipple complex, and the so-called outer circle, that means the neo position of the nipple complex according to the preoperative markings on the skin envelope of the breast. If there are so-called spare rules, so if the inner circle diameter is the outer circle diameter is more than a double of the inner circle diameter, according to the spare rule, then you will get that extreme tension, and that extreme tension can cause the flattening of the nipple. Otherwise, if you are able to create less tension for your nipple complex, but you have to undermine the nipple complex, you can have the same results. That is true. I think I completely agree. So I would like to ask that was my answer to that question, and would like to ask the other experts, Peter or Ash or Yazan or even Cicero, please.
Any
Peter,
comments?
let's go with you. Peter, let's go with Peter.
Oh, okay. Well, I think you said most of the issues, really, the diameter, how much skin resection you're doing, how much you're stretching the neo-areola. And I think also, look at the overall projection of tissue you have behind the nipple. Of course, you don't want there to be too much pressure behind the neck, because that may render it venous congested and therefore liable to problems. But of course, I showed one example where you can maybe put a little auto augmentation if it's really flat, as long as there's not excessive tension behind it, then that can give a little bit more protrusion. I think in most cases, though, it'll be okay. I think my nipples flatten more with a nipple-sparing mastectomy than, I must say, with the therapeutic mammoplasty. So I think you've said all the things I would say.
Cicero, any?
If I understand the question, because I just arrived in the end of presentation, unfortunately, about how much tissue you should let behind the nipple and areola complex in a therapeutic mammoplasty. I think that if you use inferior pedicle, for example.
No, I don't, Cicero, that was the question. Was one of the questions was that they get flattening of the nipple rather than maintaining the conical shape of the nipple. And is that to do with the skin resection volumes, or are there any ways that you can mark?
That's a good question. It's a good point. I think it's more related to the pressure that you let when you close the mammoplasty. That's the biggest problem. So when you plan your resection, you plan the position of the tumor and the reconstruction, Sometimes it's necessary to remove a little bit more because of the depression that you left behind. Most of times in superpedicle, it happens more in superpedicle. So the risk is more related, according, in my opinion, according to depression that you have left behind, more than the thickness of the flap.
I notice also some people stretch the nipple quite a lot before they mark the nipple. And if you stretch it quite a lot, you don't have lots of skin left. When I mark my nipple, I don't stretch at all. I just put the Freeman's or the cookie cutter and mark there, because nipples were not supposed to be very stretchy and smooth. They're wrinkly, and if you stretch it that much, it will flatten. That's common sense, I think. Shall we take one of the other questions, Ash?
Sure, please.
So the people.
Sorry, Zoltan wants to make a point.
Zoltan,
just as a short remark. According to two techniques, one is like Peter showed or Cicero showed, that the surgeon is able to mark up just at the beginning the neo-periareolar incision, the neo position of the nipple oral complex already, and so the most cranial point of the incision is just done just at the beginning of the surgery. And I can recommend for those who are not so familiar with these inverted mastectomies or therapeutic mammoplasties, just to mark the nipple position, the neo-nipple position, and not the neo-areolar position. And don't place your periareolar incision just at the beginning of your operation, just after you had the excision and you had everything, and you are trying to reconstruct your breast, yeah, because then the highest point of your incision is already done just at the beginning of the operation, and it's almost impossible to correct that without scar, yeah. So for those who are really not so experienced surgeons, mark better the neo position of the nipple, and just after that, if you have enough experience like Peter or Cicero, then mark please and the periareolar incision. Of course, this is just a recommendation. You can of course do your practice. Each of us, but even though you can prevent probably that the rising sun phenomenon, that the nipple oral complex is just looking out from the bra, which is very unpleasant for our patients. Yeah,
I think that's an excellent point, and that's exactly what Peter said, is don't commit, especially when you're new and you're doing something for the first time. You have to leave yourself the space to compensate for your inadequacies. I think that's a brilliant point, Zoltan. Well made. Just one last point. Sorry, Cicero. And then
one thing that I totally agree with you, Zoltan. And one thing that I usually say to my fellows and to my residents is that it's do the measurements and don't go beyond your measurements. And we have, of course, if I do, for example, 5, 4, 4, and 7, what I sometimes I do a joke. This is my credit card number, 5, 4, 4, 7, 7. Actually, you don't have to go beyond this. It's not necessary to be in 5, 4, 4, and 7, 7. But don't go beyond this, and don't go beyond 17 from the external notch and the new areola, because otherwise you have a better, you will not have a good result, and can compromise not only the position of the deep areola complex, but when you build your breast or you rebuild your breast, you can have it. And I agree with you. That's a good trick. It's a good for who are beginning in oncoplastics.
And just again from the experts, is there any difference, or do you feel that there will be a difference in how you approximate those two edges together? Whether it's like a continuous thing, or you take interrupted stitches. Does it make a difference, or if you've done it wrong, it's not going to make any difference?
I don't know if I can answer this question.
It's a trick question.
I think that it is in your drawings. As I told in my presentation, it's all in your drawings. If you put more stitches or less stitches, it doesn't matter.
I think Zoltan said no
big
in the
problem
start.
is in your joints. Put more relaxed your joints in order to close, not so stretched. Otherwise, you have problems, and you can have an opening your wounds in the post-op.
Yazan, next question.
Zoltan, before we go to the next questions, yeah.
Just a remark. One exception, I think. I recommend to put single sutures to the IMF and then a subcutaneous running of running suture with an absorbable 2.0 suture, because then you can form a very, very significant and characteristic IMF, and you can bring a little bit together your breast, and that makes a much better form and much better shape for your breast. So if you would like to have a really a nice shaped breast, then the very characteristic IMF is, I think, mandatory for that.
That's great. There is a question. There's two questions that are really roughly about.
Hang on, Peter wanted to make a point, and then
just to say, I use the stapler a lot. You know, I like to staple, and then if it doesn't quite look right, you can take the staples out very quickly before you stitch. My stitching is going to be my final stitch. I don't stitch and restitch. So get a stapler, because it just makes, like the Americans call it, tailor tacking.
tailor tacking, yes.
It's a really good way to iteratively fix things and make them look better.
Now, there's a couple of questions that just go around the same thing about gigantomastia and nipples. And can you keep the nipples on pedicles, or what do you think about free grafting of the nipple? I think from what we've seen from Zoltan, everything nearly can be kept on a pedicle.
I think that is an old dogma, that if you elevate the nipple aureolar complex more than 10 centimeters, then the nipple aureolar complex should be transposed as a split thickness skin graft to the neo position. I think one should understand that plastic surgical concept, that everything goes about the excellent vascular supply and angiosomes. And if your tissue is well vascularized after the mobilization, after excision, and so on, then you will not have any infection. You will not have necrosis. You will not have these kind of problems. And for that, you have to be able to understand that subgross vascular anatomy, which was presented by Peter and by me today, actually. And if you choose the superopedicle, inferior pedicle, superomedial, superolateral, etc., you have to think about, part after part. If you mobilize skin pedicles, if you mobilize parenchyma pedicle, which of the significant vessel should be preserved, and which of them will supply your pedicle. As mentioned by Yazan, you can have a glandular pedicle, or even you can transpose skin island if the skin excision, the overlying skin of the tumor is necessary. It makes no problem. But just think about the perforator vessels located in the viranga, or the superior or lateral or even medial perforators, to preserve them. Yeah, this is like as mentioned by Yazan, nipple sparing mastectomy, or the modern mastectomies. Yeah, it's not the thickness of the skin flap or the skin envelope is important than to preserve superior perforators, superior mammary artery, or medial perforators, or even the branches of lateral mammary artery. So if you have a good vascular supply, they can do everything, even undermining the nipple aureolar complex, even excision of the nipple and preserving the areola. And then later on, you can easily reconstruct the nipple from the preserved areola, skin, etc., etc. This is my opinion.
And I completely agree. If there is a blood supply reaching the nipple, I've done nipples at 45 and nearly 50 centimeters, and they said if it doesn't look healthy, then we'll do a free graft. But if you respect the blood supply, that will be great. Now we'll go to
Hang
Cicero.
on, Cicero has a point.
Yeah, just a very short comment. I agree with Zoltan and with you, Yazan. I think that it's possible to do big mammoplasties with big breasts with inferior pedicle. If you know the anatomy, the vascularization, and preserve the inferior lines in the breast, you can have good vascularization for the deep neural complex. The biggest problem that I have in my practice is for oncoplastic in patients who already had mammoplasty in the past. I think that these patients has higher risk than bigger breasts to necrosis, to a problem in terms of vascularization. For these patients, we have I have more concerns, but I don't do this toric in my practice for many years, because the results in toric they're not good. They're not good most of times, of course.
And you need to tell us where we get the magic pen from, Cicero.
You have this magic pen in Europe. It's just to know where are it. It's 5, 4, 4, and 7 points inside the magic pen.
Peter, you wanted to make a point.
Peter? Yeah, I will send to you. I will send to you.
I would like the rest of Cicero's credit card numbers, please. Actually, what I was going to say is, in fact, for our feasibility study, we had about 4 or 5 re-reductions. And I think this is where it's going to make a big difference. And this is where I think the plastic surgeons for doing aesthetic surgery may be interested in this technique, because it was so easy. I mean, it really was. I mean, even if you can't find the operation notes, you know how it is. That plastic surgeon left the country, is no longer there.
Left the country.
Now, you know, you can map the vessels beautifully. And, you know, and maybe some of those patients need an MRI, as Zoltan suggested. It can be helpful. But I think you can map it with color Doppler and acoustic Doppler in your clinic really, really nicely. And that will give you a predictable result. We've had no complications even with the re-reduction so far.
That's great.
Yes, Zoltan.
Just one suggestion for those who are not so familiar with these techniques, but you are doing a simple mastectomy, then please use a simple blade for the mastectomy. And of course, you will find the vessels, as well the perforators, as well the medial perforators, then the perforators located in the Würinger septum. You will find the superior perforate, the superior mammary vessel. Of course, after a short bleeding, you have to care about the bleedings, but so you will have and your experience where the vessels are located, and even the calibers of the vessels, you will have your experience. And another thing is, if you are doing already the oncoplastic techniques, then use your cauter. We can change the power of the cauter. Yeah. If you come close to the skin, then ask the colleagues to have a lower power. Then if you are in the parenchyma, then ask the colleagues for a higher power for your cauter. And please, the cauter, you don't use the cauter like a spade. Only the tip is working. And yes, yeah, exactly, yeah. And so automatic technique, and you can use the cauter without the electric power, yeah, to dissect. And if you weight the vessel, yeah, then don't go through like a blind horse, yeah. Then stop a little bit and use your cauter and dissect the tissue and try to find your vessel. And if it is possible, trying to preserve the vessel, yeah. I think if you have, this is like driving. After a certain number of cases, you will have that technique, that atraumatic technique of preparation, and you will know that at this location you have to slow down a little bit, and 5 centimeters laterally you can go on and do your dissection. Yeah.
And that's
so don't go like a Jedi. Be more gently.
So in some places you can run, some places you can walk, and some places you need to crawl. And And I still remember that most of your operating, you need to do it with your left hand that opens the planes. That's something I learned from Ash. Unfortunately, I have to confess online for that. And your diathermy tip, you should always see your diathermy tip. The only thing that we haven't talked about a bit is the extended primary and secondary pedicles. And we don't want people to just jump into doing those things if they're not comfortable already with their mammoplasties. Those can go wrong big time. Am I correct in saying that, Peter?
Yeah, sure. I mean, all this is hopefully done with supervision and training. Just really to give you the principles, I think. Yeah, definitely. And don't make something an irreversible move too early on before you know what's going on. So I try and isolate the neck pedicle, as I mentioned. Then I make sure I've got a generous cancer resection. I then X-ray the specimen to ensure that I think my margins are clear. If I have a close margin, I will do that before I start rearranging the breast, because that's the other thing, a very good point. Do your clips for the radiotherapist for the tumor bed before you start doing the breast origami, because then you will get very confused. And the other thing is that, again, really important, make good notes and if possible a diagram to show what you've done. The minimal operation report is to show which neck pedicle you've done, where the cancer was, and if you had secondary pedicles, where they came from and where they are now. And a diagram, is 1,000 words. So, good documentation is part of it. So, if you're a trainee, document exactly and watch very carefully what your consultant trainer is doing. Question them, of course, and learn documentation first, understand what you're seeing.
So, Ash, are we going to continue? Because
I think we need to end this at some point. I think it's a brilliant session. Thank you all. I think if the registrars and trainees take on one message, it's the fact that you have a wealth of experience. You have great surgeons there. Each one of them is a doyen, is an international figure, is a key opinion leader, and all of them are saying, be careful, be careful, be careful. This is because we've all been through the phase that you have been gung-ho. We're all very nice and cutty happy. And then you realize when you live with your mistakes about how you need to then claw back and draw back. So learn from our mistakes. Don't make the same mistakes that we made. Plan as Cicero said. Use anatomy as both Zoltan and Peter are saying, and don't commit irreversible steps. I think that's the message from today. I think all of you have been very, very clear and succinct. Thank you all for making this one of the most successful ESSO webinars. And on a personal note, I'd like to thank Peter for bringing in the Endomagnetics to sponsor this webinar, because that way we could have 270 people across the globe from various countries taking part at no cost to themselves. And we hope long this may this